We have none other than the renowned cardiologist of Mumbai, Dr. Sadaanand Shetty sir. Sir is the professor and ex-HOD for Department of Medicine, Dr. D.Y. Patil University, Mumbai. So welcome to the show, sir. So again, going to the same question, do we need to go beyond LDL as far as the assessment of the atherosclerosis and thereby the cardiovascular morbidity and mortality is concerned?
Thank you, Sau. I agree with the concept of treating triglyceride, particularly when we give statin therapy, in spite of achieving the LDL target. When you have high triglyceride, particularly when the triglyceride is more than 200, with the low HDL less than 34 or so, particularly in the Indian setting, since we have the triad of dyslipidemia, which means high triglyceride, increased amount of small dense LDL and low HDL, and so there is a strong reason, unlike the Western dyslipidemia, particularly the heterogeneous dyslipidemia or diabetic dyslipidemia, recently there are a lot of the data emerging, even the long-term follow-up studies are available to us, suggesting that triglyceride reduction is an important component of lipid therapy.
Okay. Alright, sir. So as you say, sir, Indian dyslipidemic patients differs from the other parts of the world. So do we really need to focus more on the triglyceride than on the LDL as far as the Indian dyslipidemic patients are concerned?
Yeah, agree, because in Indian dyslipidemia, in fact, one of the major metabolic abnormality is the triglyceride metabolism. When you have a triglyceride dysmetabolism, we get increased amount of small dense LDL and low HDL.
Okay.
So the starting event is triglyceride dysmetabolism, because when the triglyceride, the cholesterol esters like present in the VLDL, exchange with the cholesterol esters with LDL as well as HDL. When the cholesterol esters exchange with the LDL becomes small and dense LDL, and when it exchanges with the HDL molecule, HDL becomes small and that gets excreted in the urine.
Okay.
Because of these two things, unless we tackle the triglyceride metabolism, particularly in Indian setting, that also in setting of a diabetic dyslipidemia, by just reducing the LDL even up to 50 milligram, or giving HDL therapy, like as we have shown, both in AMI and HPS2 Thrive study, that is not been found to be useful because of this reason.
Okay.
So I am a strong proponent that we have to tackle triglyceride metabolism, we have to tackle the triglyceride the reduction, and we have to go beyond LDL reduction. What I would say, like a triple target,
Right.
that reduce the LDL, reduce the triglyceride, and try to improve upon HDL.
Right, sir. So as far as the reduction of triglyceride levels are concerned, according to you, sir, what should be the level we should always target for reducing the triglyceride levels?
At least we must target less than 150. What AHA in 2011 told us, even less than 100 milligram is the desired one.
Okay.
So I would think in our patient, particularly with already established cardiovascular disease, getting the triglyceride less than 100 will be ideal, particularly after the few long-term studies, like one where the loss of mutation ApoC study, which has been followed up for 34 years. Secondly, the strong heart study, which they follow up almost the 17 years. And then one study, bezafibrate infarction intervention trial, where now follow-up is available for 22 years.
Okay.
Considering this, the lowest level of triglyceride with the optimum result is less than 100.
Okay. So, sir, as you rightly said, for especially for Indian dyslipidemic patient, we always should go beyond LDL and also target the triglyceride levels. So, according to you, sir, what is the strength of data that is available so that we can say more powerfully that we should target triglyceride more than the LDL?
As I mentioned previously, these three long-term studies, plus when we analyze the data of what is called as a residual risk, there is a concept called residual risk. In spite of getting the LDL less than 50, as shown in various primary, secondary intervention trial, that the risk is reduced only up to 20 to 25%,
Okay.
in spite of getting the LDL. So one of the factor could be lipid and the other is non-lipid, which we have no control. But at least in the lipid parameter, non-HDL factors, in that things like the triglyceride, things like small LPA, maybe the IDL, VLDL. So all these things could be accounting for the residual risk. So therefore the importance of reduction of triglyceride. And now since we have got the long-term studies are available, particularly the bezafibrate infarction, the prevention trial, as well as trial like 34-year follow-up, as I mentioned, loss of mutation ApoC, as well as the strong heart study. I would strongly recommend, now we have got evidences with a good long-term follow-up. Even in acute coronary syndrome, importance of triglyceride reduction recently shown in 2 trials called DAL outcome and miracle studies.
Okay.
So even in acute coronary syndrome, we just leave the patient on 80 milligram atorvastatin, rosuvastatin 40 may not be correct, because the recurrent ischemic events in these 2 trials have shown significantly reduced when along with the statin you give therapy to reduce the triglyceride.
Right.
So I would strongly feel we in our Indian patients, when you look at the lipid analysis, lipid report, look into all this total cholesterol, triglyceride, LDL, non-HDL, then the ratio between the triglyceride upon HDL, and see the gap between LDL and non-HDL is more than 30-40, or measure the total cholesterol minus LDL minus HDL, that remaining is a remnant particle. If it is more than 20, these are the strong determinant of highly atherogenic milieu, and that is what we need to tackle in our Indian patients.
Right, sir. So, sir, thank you so much for such a valuable information, and need to go beyond LDL and focusing equally on the triglyceride level so that we can reduce the incidence of ACS. So, thank you so much.
Thank you, sir. Okay.